perinatal infection in the mother, etc. The history check is very important. Second is clinical examination. Look for any obstruction like wax, polyps, tumors. Look for fluids in the middle ear. Signs of autosclerosis can be tympanoclerosis, autosclerosis. 24 test comes under clinical examination, which is very important for as a clinician. We need to do 24 tests. Third diagnosis part is audiogram. I'll come to it later. 24. Here, a vibrating tuning fork is kept on patient's mastoid, and once the patient stops hearing, bring the tuning fork just in front of the external auditory canal and ask whether the patient is hearing or not. In normal cases, patient will hear. So it indicates air conduction is more than bone conduction. So it is normal, and also it can be normal, positive in sensory neural hearing loss. If the patient doesn't hear, that is ring is negative, and it indicates bone conduction is longer than air conduction, and it indicates a conductive hearing loss. Okay. Second test is Weber. Here, vibrating tuning fork is kept on patient's forehead or either teeth, and ask the patient which side the patient is hearing, left side, right side, or center. Normally, if the patient will hear in the center. If it's lateralized to one ear, it means definitely the patient is having definitely the patient is having hearing loss. So in case of conductive hearing loss, it is lateralized to the worst ear. And in case of SNHL, sensory neural, it is lateralized to the better ear. So in that case, we can actually give a provisional diagnosis to the audiologist that he's having Weber to left, he's having a conductive hearing loss. So it makes makes the diagnosis easier for them also. Third one is absolute bone conduction, not routinely done here. Here the patient's bone conduction is compared with that of the examiner, provided the examiner is having normal hearing. Here, external auditory canal of both patient and the examiner should be obstructed, and the vibrating tuning fork is kept in the mastoid and then on the examiner. If the patient and the examiner hears for the same duration of time, it is conductive hearing loss. If the patient hears the tuning fork for a shorter duration, then definitely the patient is having sensory neural hearing loss. Schwartz's test is also similar to absolute bone conduction, but except the external auditory gain test is not included. Other two tests are Bing test, Gillies test. These are tests of bone conduction. Bing test here, it examines the effect of occlusion of ear canal on hearing, and Gillies test, it examines the effect of increased air pressure on ear. So not done routinely. Now we'll see the audiograms, and we'll go through the basic audiograms we get in the clinics. Here, the pure tone average is taken. Air conduction thresholds are measured for tones of 125, 250, 500, 1000, 2000, 4000, and 8000. Again, for bone conduction thresholds are measured for 250, 500, 1000, 2000, and 4000. And a graph is represented. The difference in thresholds of air conduction and bone conduction, that is air-bone gap. If it is present, it indicates conductive hearing loss, and the degree of degree of difference in threshold indicates the degree of conductive hearing loss. This is one common audiogram we get. It's rotates media with effusion. Here you can see the red line is actually right side, blue is left side, as you all know. The right side air conduction graph and the right side bone conduction graph, you can see a gap there. Clearly air-bone gap is seen. So it indicates a right-sided conductive hearing loss. This is an example of sensory neural hearing loss, presbycusis, age-related hearing loss. Here you can see bilateral, both ears, right and left, you can see a sloping down hearing loss. So it indicates presbycusis. Meniere's disease, as I told earlier, a low frequency hearing loss is there on right side and is sloping upward. Along with the clinical features of tinnitus and giddiness, you can diagnose it as Meniere's disease. Vestibular schwannoma, usually it's unilateral hearing loss. Here also it is sloping down, sensory neural hearing loss. No airborne gap is there. So right side sensory neural hearing loss, unilateral. Mixed hearing loss. Here we can see both conductive and sensory neural component. You can see the airborne gap bilaterally on right side and left side, and also the threshold. The pure tone thresholds are reduced, not the normal 15-20 dB. It has come down to nearly 40-45 dB. So this patient is having mixed hearing loss. Last one is noise-induced hearing loss. Here, a typical pattern of notching is seen at 4,000 to 5,000 kilohertz. You can see bilateral noise-induced hearing loss with the notching nearly around 5 kilohertz, and it's typically of noise-induced hearing loss. Other component of audiometry is tympanometry. So tympanometry is based on the principle that when a sound strikes the tympanic membrane, some of the sound energy is absorbed and some part is reflected. A stiffer tympanic membrane will reflect more of sound energy than a compliant one. So by changing the pressure in the external auditory canal, in a sealed external auditory canal, and then measuring the reflected sound energy, it is possible to find the compliance or stiffness of the tympano-ossicular system. These are the types of tympanograms we get usually. Normal type is type A, you can see at the level of zero pressure and maximum compliance is seen. Second one is type AS, that is you can see at zero pressure the compliance is actually bit lower, that is second type AS is reduced compliance, is seen in otosclerosis commonly. Third type, you can see the compliance is very high at zero negative pressure, that is example is ossicular discontinuity, increased compliance is there. Fourth type is type B, you can see flat curve, dome shaped curve is seen. Usually it is seen in fluid in the middle layer, that is otitis media with effusion or any obstruction in the external auditory canal like wax can give this type of hearing loss. And the C is actually maximum compliance is seen at negative pressure, that is around the 200 250 mark, minus 250 mark, you can see maximum compliance. That indicates a negative pressure in the middle ear, usually seen in eustachian tube obstruction. Acoustic reflex is tested along with the tympanometry. Here it is used to test the hearing in infants and young children, to find malingering, to detect cochlear pathology, atrial lesion, brainstem lesion. And I'll just go through the special tests of hearing. Before that, we have to know what is recruitment. Recruitment is a phenomenon of abnormal growth of loudness. Usually, see, recruitment phenomena is seen in cochlear lesion. The ear which does not hear low intensity sound begins to hear greater intensity sound as loud or even louder, and it becomes intolerable to these kinds of these patients. So loud sounds becomes intolerable. So these are poor candidates for hearing aids. These are seen in typically in regions of cochlea. So to test recruitment, we have alternate binaural loudness balance test, ABLB test. Here, a tone is played alternatively to normal ear and an affected ear. The intensity in the affected ear is adjusted to match the loudness of the normal ear. So the test is started 20 decibel above the hearing threshold of the deaf ear and then repeated every 20 decibel. So in normal hearing loss or in conductive hearing loss, the initial difference is maintained and graph will be in parallel lines. But in patients with cochlear lesion, recruitment occurs or over recruitment occurs. That is, at some point of time, the graph actually coincides and there's the intersection on the graph. So that indicates recruitment and is seen in cochlear lesion. Second test is short increment sensitivity index, CC test. The patients with cochlear hearing loss can distinguish small changes in intensity of pure tone than with normal person. So here, what we do is a continuous tone is presented 20 dB above the threshold and sustained for 2 minutes. Every 5 seconds, the tone is increased by 1 decibel, and 20 such blips. That is very small amount of intensity is increased. Only 1 dB is increased. So the patients with cochlear lesion will detect that blips easily. That is 70 to 100% of the blips are detected by cochlear patient. Normal or conductive hearing loss people, it is seldom more than 15%. Let us this threshold tone decay test. This is a measure of nerve fatigue and is used to detect retrocochlear lesion, that is neural lesions. Normally, tone can be heard continuously for 60 seconds. So in patients with retrocochlear lesion, there will be nerve fatigue and they fail to hear the tone for 60 seconds. So here what we do is a tone of 4 kilohertz is presented, 5 decibel above the threshold, continuously for 60 seconds. If the patient stops hearing, again we increase the tone by 5 dB. And the process is continued till the patient hears the tone continuously for 60 seconds. So, if the value is more than 25 decibel, that is threshold tone decay is more than 25 decibel, it indicates retrocochlear lesion. Coming to evoked response audiometry, we have electrocochleography, PERA, OAE, etc. First one is electrocochleography. Actually, we need to know just the basic thing what we have to look for. We have to look for the summation potential to action potential ratio we have to look for. Normally, it is less than 30. So, if it is more than 30, it indicates a cochlear lesion. Next is BERA test, also known as auditory brain stem response. They actually elicit brainstem response to auditory stimulus to find this is used to find the integrity of the central auditory pathway. Usually we get 7 waves. Wave 1 is from the distal part of cranial nerve 8 is nerve. Wave 2 from the proximal part, wave 3 from the cochlear nucleus, wave 4 from the superior liver complex, wave 5 from the lateral meniscus, 6 and 7 from the inferior colliculus. ABR is used for screening infants and to determine threshold of hearing in children who are not cooperative, to find malingering, to diagnose retrocochlear lesions like acoustic neuroma, brainstem pathologies like multiple sclerosis, and also to monitor intraoperatively, monitor the 8th nerve during surgeries of acoustic neuroma. OAE test. OAE is commonly we see OAE test done for newborn. Actually, it's not that specific test because 50% of normal individual, 50% normal individual is absent. But absent, we do it as a screening test here. Here, the low intensity sound produced by outer hair cells in cochlea are detected, and we give the result as pass or fail. So it's not that specific. Once if the baby is having negative result, we wait for another 2 weeks and we repeat the test. So it's not the diagnostic test of hearing loss. Again, it's divided into 2 types: spontaneous and evoked uses, and also to distinguish cochlea from retrocochlear lesions. Management part, I will just go briefly to the management part. The ultimate goal of the management is to restore hearing, to assist hearing, and oral rehabilitation. Restore hearing means you need to find out what is the cause of the hearing by clinical examination, investigation, audiograms, etc. And it can be corrected, you should do it. That is, conductive hearing loss can be any obstruction like wax, foreign body, polyps should be removed. Or any inflammation of the external auditory canal can be treated with analgesics, antibiotics if indicated, anti-inflammatory drugs. In congenital anomalies of external auditory canal can be corrected by surgery. Conductive components in the middle ear, like fluid in the middle ear, we can treat with decongestants, nasal decongestants, oral decongestants. If it fails, go for laryngotomy. Any mass in the middle ear should be removed surgically. Disruption of ossicles due to trauma can be corrected by ossicular reconstruction. Fixation of ossicle chain can be corrected by staphylotomy. So basic cause what it is, we have to correct. Eustachian tube blockage again, it can cause negative pressure. So decongestants are very helpful. Either steroids, and if it fails, next option is very better. Sensory neural component, sensory neural part is mostly permanent, but some causes are preventable. As I already told, ototoxicity. We can actually stop the drug, or we can monitor the hearing when we start drugs that can cause hearing loss, anti-malarial drugs and all. We can do an audiogram for that patient. And if we detect some hearing loss initially, we can stop that drug, or we can use alternate drugs. Similarly, sudden sensory neural hearing loss. If you treat the patient within 72 hours of sudden sensory neural hearing loss, there is 70 to 90% chance that patient can have normal hearing. So we treat with intratympanic steroid injections, intravenous methylprednisolone steroid injections, and later convert to oral steroids and monitor audiograms on daily basis. Another preventable cause is noise-induced hearing loss. Here, we can be prevented, like by using earmuffs, earplugs, by giving counseling to patients who are at risk of noise-induced hearing loss, and we can do yearly or frequent audiograms for factory workers who are exposed to high intensity noise, so it can be prevented. Assist in hearing means hearing aids can be done, middle ear implants can be done, cochlear implantations can be done, sign languages, auditory rehabilitation. The various types of hearing aids nowadays you can get in the canal, behind the ear. Multiple types of hearing aids are there. Middle ear implants we don't use it, and cochlear implantations are also there. And we don't do it here in Kannur particularly, but Kozhikode and Cochin and all, we are doing this cochlear implantation. Oral rehabilitation. If the hearing loss is permanent, this oral rehabilitation part is beneficial. The services and the procedures for facilitating adequate receptive and expressive communication in individuals with hearing impairment. So what are the components? Auditory training, that is emphasize listening skills. Speech reading, that we tell as lip reading. Speech training to conserve, develop, and prevent the deterioration of current communication skills that the patient might have acquired during his course of life. So speech training is also important. These are all beneficial for patients who are already diagnosed as permanent hearing loss and no other options are there for rehabilitation. Thank you.
Thank you, sir. For that was an incredibly informative session. Now the session is open for discussion.
So, can you explain that how to read an audiogram a bit more detailed manner?
Okay. Audiograms actually you need to look, you need to know the symbols actually. What type of graphs you are having, air conduction, mode conduction. Usually right side we mark it as the red color, left side blue. That's clear. We have markings there. Right side with a circle in between. It indicates air conduction. For left side, it is actually cross mark. So we mark actually with the pure tone we give, and at what level the patient is hearing. We mark it on the graph and we get a graph there. And bone conduction also similarly we measure. Air conduction we measure with hearing with what we call an earphone, and for bone conduction we use a device that's kept in the mastoid. So we get two graphs there. And comparing the graphs on one side, if you're looking at the left side, compare air conduction with that of the bone conduction. If there is a gap in between air conduction and bone conduction, it indicates conductive hearing loss. Usually the graph will come as single line around that 0 to 10 or 10 to 20 range. That means its hearing is normal. So if it is below that, that is the graph line is coming below, that is below 25 or 30, it indicates neural hearing loss. That's the basic thing.
Any other queries?
Thank you, Dr. Abel sir. That was a very informative session.
Hello? Hello? Sir, can you explain about hello? Sir, it was a very nice and informative session. Sir, can you explain about masking? Masking, you are asking. Masking actually, to avoid the outer noise, we do masking. Details actually, you can contact the audiogram, audiologist actually. We are not doing that audiometry procedures regularly. To clinics, we are not doing this. Interpretation of audiogram, I will tell you. Procedures, it's better to get a class from audiologist and detailed evaluation and detailed method of audiometry you can get it from audiologist.
So that was a very informative session. Thank you, Dr. Abel sir. Now, I invite Dr. V.K.V. Balakrishnan sir, Professor and HOD, Department of Salakya, Government Aveda College, Kannur, to present a memento as a token of appreciation to Dr. Abel sir. Sir, please. So that was the end of our morning session. We'll be having the next session after lunch break. So it will be lunch break will begin by 12:50, and I request everyone after the lunch break to be seated in our seminar hall.
Drinking water facility has been provided in the next room.
As per green protocol, we are not providing water by plastic water bottles. So instead of that, we have provided water next to the room, and I request all the delegates to take water from here. Since the lunch break is getting delayed, on this occasion, I invite all the delegates to have this interactive session. Delegates can just come forward and just you can self-introduce yourself.
Dr. Sridhar, nursery and hospital join as a man, Salakya PG. Dr. Manika Ike, Salakya PG, and Puta Ayurveda Product Medical Officer, Specialist Medical Officer, Government Hospital, Pioneer. Yeah, University, Padhanama PGM, Government Ayurvedic Dispensary, Ayurvedic Jodi. ജില്ലയിലെ കസ്റ്റഡി ചികിത്സയാണ് PG ബേസ്ഡ് പ്രിയ കാസർഗോഡ് ജില്ലയിലെ കാട്ടിപ്പുഴ ഡിസ്പെൻസറി സീനിയർ മെഡിക്കൽ ഓഫീസർ.
ഞാൻ ഡോക്ടർ ഷംസുദ്ദീൻ GH വടകരയിലെ SMO ആണ് കോഴിക്കോട് ജില്ലയിൽ. ഞാൻ ഈ കോളേജിൽ പഠിച്ചാണ്. വൈഫും മെഡിക്കൽ ഓഫീസറാണ്. വൈഫ് ഗവൺമെന്റ് ഹോസ്പിറ്റൽ ബാലുശ്ശേരിയിലെ മെഡിക്കൽ ഓഫീസർ.
Dr. Swati Krishna, my birthday
Kanur Savitri, ഞാൻ ഡോക്ടർ സ്വാമി ഗവൺമെന്റ് ആരോഗ്യ ഡിസ്പെൻസറിയുടെ മെഡിക്കൽ ഓഫീസർ.
ഞാൻ ഡോക്ടർ അരുമ കുറുമാത്തൂർ ACHസിലെ മെഡിക്കൽ ഓഫീസർ.
ഡോക്ടർ സതീഷ് മെഡിക്കൽ ഓഫീസർ ആണ്.
ഡോക്ടർ മെഡിക്കൽ ഓഫീസർ IPC ചെറുതാഴ്.
ഞാൻ ഡോക്ടർ വിജീഷ് കേളി, സുൽത്താൻ ബത്തേരി, വയനാട് സുൽത്താൻ ബത്തേരി താലൂക്ക് ആയുർവേദ ഹോസ്പിറ്റലിലെ സ്പെഷ്യലിസ്റ്റ് മെഡിക്കൽ ഓഫീസർ.
ഞാൻ ഡോക്ടർ അസ്ലീന, വർക്ക് ചെയ്യുന്നത് ഗവൺമെന്റ് ആയുർവേദ ഹോസ്പിറ്റൽ ബാലുശ്ശേരി, കോഴിക്കോട് ജില്ല. ഞാൻ ഇവിടെ പഠിച്ചത്. ഞാൻ ഡോക്ടർ കുമാർ, ഞാൻ അസോസിയേറ്റ് പ്രൊഫസറാണ് നന്ദിയുടെ ആരോഗ്യ. ഞാൻ ഡോക്ടർ നന്ദിയുടെ ആയുർവേദ മെഡിക്കൽ കോളേജ് ചാലക്കര ഡിപ്പാർട്ട്മെന്റ് ഹെഡാണ് അസോസിയേറ്റ്.
ഞാൻ ഡോക്ടർ സന്ധ്യ, മെഡിക്കൽ ആയുർവേദ മെഡിക്കൽ കോളേജ് അസിസ്റ്റന്റ് പ്രൊഫസറാണ് ചാലക്കര.
ഐശ്വര്യ, PNPS ആയുർവേദ കോളേജിൽ അസിസ്റ്റന്റ് പ്രൊഫസർ ചാലക്കര.
We will begin our discussion after a break.
ഫയലിൽ വെച്ചിട്ടുള്ളത് റെസിപ്റ്റിന്റെ ഫയലിൽ വെച്ചിട്ടുണ്ട് വെച്ചിട്ടുണ്ടോ അത് ഫയലിൽ വെച്ച്
എന്ത് സ്ക്രീൻ കൊടുത്താൽ മതിയോ?